Hello, everyone, and welcome to this week's edition of the AHA podcast, current events and topics that will help you help your clients. So great job, Alyssa. I really enjoyed watching last week's podcast, and I thought you did a good job on AHIP, and I thought Amanda did a great job and all the nuances of recertification. What are you hearing this week from the agent care team, Alyssa?
Yeah, we're in the thick of it right now as far as certifications go. It seems like carriers are opening up their certifications almost daily here. So AHIP has been open since June 22nd, but the carriers usually follow suit within a couple of days, if not a couple of weeks after. So we're plugging away. Actually, just took my final exam today
Good
and knocked that
job.
out. So we're trying to get that knocked out as quickly as possible. Everyone on Advocate takes AHIP. So we're getting some questions on certification, getting a lot of questions about contracting. Now is the time of year when agents are looking at what carriers they might need to add to their portfolio to be ready to sell for AEP. So we talked about getting those contracts and certifications done as early as possible, so that they can be ready attending those agent carrier trainings, so they get those first looks. So we're getting quite a few calls on that, assisting agents through contracts.
Thank you. And how about you, Jacqueline? What's the client care team buzz? What are the phones ringing with questions about?
Yeah, well, today's July 1st, so it's the first day of the GLP-1 Bridge Program demonstration run by CMS. So we are getting a lot of questions from members that are interested about this program and wanting to know how they can qualify and maybe access these medications. So we've put a training together internally yesterday to go over the program with our client care team specialists so we can help members. And I know a lot of agents are likely getting questions too. So we look forward to going over that more today.
Well, good. Yeah. So I'd like to change the venue a little bit today compared to what we normally talk about because I enjoy the different topics and the different perspectives. But I'd like to go a little deeper since I know you already prepared a training and some guidance too to help clients as they're talking to their doctor. So why don't you take that away, Jacqueline, and feel free to screen share if you want. And the one thing I'll say before we get going is how convenient that CMS has a national infrastructure of trained professionals, state licensed, local community based insurance brokers, support and management entities like FMOs, field management organizations. And it's all just there with the knowledge that you need so that as this bridging program becomes available, which is a wonderful thing, it's great, that we're taking this new technology, this new capability that science has brought us and we're applying it to a challenged part of the population. When I was working with Toby Cosgrove when I wrote my book so many years ago, he said at that time that the two biggest killers were smoking and obesity. And so here we are with, help for both. So with that, I'll just say, take it away, Jacqueline.
Awesome. Thanks. And I'm going to transition to the slide and we can edit later. Awesome. So the Medicare GLP-1 Bridge Program that started today, our team did put together a guide that can be helpful for Medicare beneficiaries as they want more information about how to navigate it. CMS.gov does have great information out there for providers, pharmacists, and also Medicare.gov has ways you can see if you're eligible and qualify for this program. So all of that's out there, and this just summarizes it specifically for the member and the perspective of the member, just to be most helpful. And this is great for agents as they're helping their clients navigate this program. First, we'll sort of start out with what the program is. So it's starting today and we'll wrap up through December 31st, 2027. And this is a program for eligible beneficiaries with Part D coverage under Medicare to see if they qualify for GLP-1. Specifically, this program covers 3 eligible medications, which are shown here on the screen. And once you qualify, you're eligible for any of these drugs for a $50 per month copay. It's important to note that this is separate from your Part D coverage. It actually does not run through your Part D coverage. It runs directly through Medicare in this bridge program. So you just have to have Part D coverage in order to qualify. So most MAPD members qualify as long as, and members with standalone prescription drug coverage as well.
So you're saying it doesn't go through the Part D formulary coverage, but you have to be eligible for Part D for you to qualify initially.
Yes, that is correct.
But then there's other things that would qualify too, right? So not everybody that qualifies for Part D is going to be entitled to participate in the bridging program, right? And
That's correct.
you're going to get into that.
Yep, there are some other key considerations for eligibility, um, and they're related to clinical criteria as well as prior GLP-1 use. So specifically, you have to meet all these criteria that you kind of see here on the screen. We mentioned they have to be eligible for Medicare Part D plan. They also had to have never received a GLP-1 medication through their Part D plan before. So that's really important. They also cannot have type 2 diabetes, moderate to severe obstructive sleep apnea, or fatty liver disease. Most of the time, it's because members with these conditions are usually taking important medications through their formulary, through their prescription drug coverage, and should continue to do so. So if you have Part D coverage, you've never taken a GLP-1 before, you don't have type 2 diabetes, moderate severe obstructive sleep apnea, or fatty liver disease, then you can see if you can qualify for one of these other health conditions.
So, so what I hear you saying is that there's a set of criteria that would allow you to qualify for the program in terms of Part D and a level of obesity. But there's also things that would rule you out of the program if you've already taken a GLP-1, if you've got fatty liver disease, if you've got type 2 diabetes. So there's other chronic conditions that they've decided should be treated differently, and then you're not able to participate in the program. Does that sound right?
Yes, that's correct. So if you have one of these conditions, you should continue to seek coverage through your Part D plan formulary.
Okay. And so tell us more. How do we actually make this happen?
Yeah, so based on other, health conditions, so you have to meet in addition to one of these criteria related to BMI, um, and apparent health conditions too. So, for example, if you met all those qualifications and you have a BMI of over 27 and you're pre-diabetic, then this sounds like it could be a helpful program for you. So the next step is always start with your doctor or prescriber first. That's where this conversation should start, because it is a medication, and it should be a discussion between the patient and their doctor. Patients can, initiate a conversation with their doctor or prescriber, and let them know that there is this program out there, and to kind of discuss their healthcare goals. This program is supposed to be a weight management program, right? So it's supposed to help people get healthier, and the doctor is supposed to have that conversation with the patient to improve lifestyle management. So, they'd come up with goals together. This is part of your goals: to lose weight, be healthier, eat the right foods, accompanied other things as well.
Well, this is really interesting, Jacqueline, because this matches the advocate philosophy that the primary care doctor is the center of care, right? They are the relationship that we're trying to enable and encourage. But at the same point, CMS has made some rules that good policy around the program. So there's rules and there's economic impact, and so now the primary care doctor will also have to have some general awareness of where the breakpoints are in the economics so they can consider that variable in their overall care plan. Isn't that interesting?
Yes, absolutely. So I think that conversation is important. Always start with the doctor And if the doctor needs information too, they can also read about it on CMS about the qualifications. So I wouldn't be surprised if patients need to do a little education with their doctor too. And once the doctor kind of reviews, the eligible medications, and they agree to kind of start and that they could likely qualify for, they would work out on the dosage with that patient, depending on their needs. And then it's the doctor's job at that point to actually send a prescription to the pharmacy for that, one of the qualified GLP-1s and the strength. They're actually supposed to put on there specifically send to Medicare GLP-1 Bridge for weight management. So that's the instruction given to providers. And of course, any obesity diagnosis to accompany that where appropriate. And then from there, the script is sent out. And so what can the member do next? Take their script to the pharmacy, or if the pharmacy got it electronically, have that conversation with the pharmacy and bring your Medicare card, the red, white, and blue card, because that is the number that the pharmacist will run because it runs directly through Medicare. If they don't have their Medicare card, they can also use the last 4 digits of their Social Security number. And lately, with some of the beneficiaries getting updated Medicare cards, I know the last couple of years, there is actually a potential that they might, provide an outdated Medicare card with the number. So just make sure that wasn't you and you're using your right Medicare number. And you want to make sure that the pharmacist has that prescription with the necessary language on there. And so the pharmacist from that perspective will do the evaluation of that script. In particular, they will look to see the script has the medication specifically for one of those 3, that they have an eligible plan type for Part D, that the prescription was filled out correctly with the appropriate language, and that there's no existing Part D fills on file for that member for GLP-1 already. So if all that looks good, they'll go ahead and transmit that bill for that prescription to the CMS GLP-1 program, most of the time electronically. And from there, the script, ironically, will come back from CMS as showing denied.
Right, right.
That
So let's just make sure that our
Yeah.
listeners, because this is not intuitive, right? So you
Right.
just explained a pretty detailed review process where first they had to qualify or not be disqualified, and then the primary care doctor or the attending physician would have to make the right details in the prescription, which will be reviewed by the pharmacy. It'll be cross-referenced against past medications to make sure, and then it'll be transmitted. And even after all that, you're saying that the right answer is that CMS is going to come back with the denial, and that's the pat response, and you should expect that. And that's not a mistake that somebody else made, although they could have made a mistake, but primarily that's their default, right?
That's right. So that's the system's way of saying, hey, this is our first time seeing this script on file for the member. We need the doctor's prior authorization. So pharmacists, please go ahead and initiate that. So that's just part of the due diligence process here. So that first decision is not a determination of your eligibility for the program. So have no fear. It's just part of the process for your first time getting this script. So from there, the pharmacist, will actually will be triggered to send a prior authorization to the doctor. And that will include just documentation regarding, their obesity, attesting to any of the conditions that qualify for them, saying they don't have type 2 diabetes, etc. And then, so once the doctor fills that out, the pharmacist will get that information back. So once they have that prior authorization, the pharmacist will submit it to CMS and the script will be there too. And then typically it takes, I think, 72 hours for a determination to come back saying either approved or denied. And then once they kind of get that decision, the member will get a letter in the mail saying, you applied for this program and this is the outcome. You're approved, you're denied. The good news there, you're having that ongoing communication in real time, so that's good. And typically, for those that qualify and do everything right, they'll get that call that their script is ready, so they can go ahead and go to the pharmacy. And
So,
uh,
so
yes,
did you just say that the beneficiary is going to get a letter in the mail saying that they were denied?
yes. So
And
if there
that's
was a denial decision
if there was a denial decision. But what about
or an
when the pharmacist submits it and the default denial happens?
So that's the upfront work. Typically that's expected. So there's no really alarm bells sounding
So
there
that
unless there's
won't
some
generate a letter to the client.
correct. What will generate a letter is when, the final determination, approved or denial. If it's denied, it will actually tell you why. Maybe
Okay.
you didn't qualify for it based on your BMI conditions, etc. So that's helpful information for this program. And if there is an issue and it's denied and it tells you why, maybe the prior authorization wasn't filled right um, or some missing information, then the doctor can resubmit the prior authorization and you can try again. But it's important to understand why it was denied as well.
Yeah. And then is there an appeals process or anything published yet on that?
Yeah, so the appeals process is really interesting. The pharmacy is actually your point of contact here because they're the ones that are seeing the prior authorization results in real time. And they're the ones facilitating this with the doctor and CMS too. So, based on the information and denial reason, that will give you the information you need on how to work it. So, for example, if the doctor just forgot to put the BMI number on the prior authorization form and it was submitted because of incomplete information, then the doctor will you can reach out to the doctor to rework that. But the pharmacy actually has a lot of this information to be helpful and to work with you. But if you're denied because you just don't qualify based on your BMI health conditions, there's really nothing to appeal. You just don't qualify.
Right, right. Well, it's interesting because in my first reaction is it seems a little bit onerous. It seems like it's a kind of labor intensive, but it reminds me of some of the presentations we've given. Whereas, there's limited resources, and what we're trying to do is judiciously match the limited resources that we have, the finite resources as a nation to the people that need it. So this is just a way to make sure that we get the most out of what we have available. And so by default, it's complicated because you have to set parameters of who's going to be the best use of this. And so that needs analysis and that matching and those rules, that's administrative overhead that's necessary to make sure that these GLP drugs and the money that funds them goes as far as they can. So it isn't meant to rule people out. It's just meant to make sure that the people that are the best fit and the best, intended audience get what they need. And so that requires the national infrastructure of community-based brokers and, advisors, right? Because there's an economic component. There's a Medicare, Medicaid type component to it. I should say Medicare. And then there's what everybody's got a role here. The pharmacist has a role, the primary care doctor role, the patient has a role, and so do the insurance professionals. So let's get on to your next part, and how do I actually get the medicine, and what happens then?
Yeah, so just a couple of last steps. Once you kind of, let's say you get the approval, you can return to the pharmacy to pick up the medication. Um, and you will be subject to the $50 copayment. And this applies to everybody, uh, even beneficiaries that are in low income subsidy, because the $50 copayment does not actually count towards Part D deductible or out of pocket costs. So this is separate from Part D. So that's just important. No, you can't use any manufacturer coupons or discounts. You're going to be subject to the $50 copayment. And this is usually for 28 to 30 day supply at a time. So you can't get anything more than that. And sometimes too, just something to keep a note of on top of the $50 copayment, there might be an additional $3 to $5 just from processing fees and sales tax too. So just beneficiaries should just keep that in mind. And then once you kind of get this too, the good news is you don't need a new, prior authorization for future refills, unless you change the medication that you're trying or using. And then just something to keep in mind too, in order to get like your next refill for the next month, if you're continuing to take this, they do want to make sure that you're at least 75% in use of it for that month. And while you're taking it, I would imagine it's just important to make sure that you're having the ongoing check-ins with the doctor, right? Because when you're taking a new medication, it's just important to make sure that you're consulting with your doctor, that it fits your lifestyle, um, and there's no other consideration. So that's the process. We can share this guide out. There's common issues and what to do also provided here, regarding if things were denied. So, we talked about in the beginning, the prior authorization and how it's normal at first, once the pharmacist submits that claim to get that denial. There's also some other interesting common denial reasons that members should know, and, their agents and client care team can help too. So, one thing that will be flagged is if, Medicare sees that they were previously on a GLP-1 under Part D. I know that, some um, people try a GLP-1 maybe before they turn 65. And so those people will still be considered for this program. This is if you just took a GLP-1 under Part D. Wrong or old Medicare ID. So no, there's real errors, but these are good things to know, and the letter will showcase that to take the appropriate action as
Well,
needed. But
Jacqueline, that was fantastic. I think, they can contact advocate and we can facilitate them. So what do the commissions look like? How much do agents get paid for providing this valuable service?
they do not. This is part of their duty, with their trusted relationship with their member, to make sure that they can access the care and resources that they need to live healthier lives.
Well, how much does advocate get paid? We must get paid a lot of money.
No, we put this together, just to make sure that our members know how to navigate this information.
Right. So the agent isn't getting anything out of this from an economic standpoint other than doing what's right for the client, which is what good agents do. We're not getting anything directly in compensation. We're just doing it because it's the right thing to do because the government at CMS has this national infrastructure of community-based professionals with the infrastructure and the service and the capabilities that a large corporation would have, and it's pennies on the dollar. And here we are doing the right thing for the right reasons. And they didn't even think about anything else. Isn't that a great story? What do you think about that, Jennifer?
I mean, I think it's great. I didn't even think about it that way, but it's smart to say that. I mean, I think they were hoping when they came out with these GLP-1 drugs that they were going to be able to just incorporate this into the current Medicare Advantage plans and the prescription drug plans. But the cost is so high that I don't think the carriers could afford to include these drugs. And so they put this in as like they're calling it a bridging strategy, right? So they're putting this out here to see what, the appetite is for it and what the cost is. But I think they're hoping eventually that they could cover some of these drugs within the formularies, which means it'd just be part of an MA PDP plan. And in which case, um, agents are getting credit for those now. And to your point, Darwin, there is a ecosystem out there of agents that are out there helping, making sure that members get access to care they need, understand how to use the plan. Here's like a new program being launched in the middle of the year. And we go out and make sure that we understand it, that we educate the agents to understand it. The agents are doing a good job trying to make sure they understand it. It's one thing to just throw it up on the CMS website. It's another thing to explain it. And I don't know. I mean, I just learned from Jacqueline as she was describing this. There's a lot to it. And it may seem really simple for the folks at CMS that put the program out there, but we know that members have a hard time understanding this. And I think the more knowledge that agents have about it, the better they're going to serve members, the better that we're going to make the whole entire Medicare Advantage program. Uh, we're getting the most amount of wellness out of every dollar here, as your famous statement is. So
Amen. That's the
I
name of the
think
game.
it's
I think
It's
a
great.
lot of
So
times that the people that watch the budget have to be fearful of how the budget's getting spent. And so that comes to some short-term thinking, which is necessary, right? You got to manage the budget. But here you have a case where this is prevention beats cure, right? The comorbidities and the other things that are associated with obesity are meaningful, not to mention the quality of life and just the human side. And so here's a great chance for no additional fee to the national infrastructure of distribution. You've got these local experts guiding people, breaking down barriers, bridging gaps, and we're doing what CMS wants to be done, right? We're executing at the tactical level. And also to your point, Jennifer, we've seen in other cases, CMS is very, very well intended. They're doing the best they can. But what was the document, Jacqueline, they put out on fraud? Was it a 30-page document or 40-page document? I forgot how long it was. We condensed it down
Yeah,
to,
and how to protect yourself from fraud. It's about 30
yeah,
pages.
which is great for us because it gives us a primer and we can build on that. But, when you get to a beneficiary that may not be literate, they may not have the level of health literacy that you would want, they're not going to read a 30-page document, right? And they're not going to read a 250-page coverage document, which is essentially their contract. That's where we come in, right? We help analyze their needs, we help understand them and what their best interests are. And in some cases, it is a fiduciary responsibility. In other cases, it's just a professional obligation. There's a code of ethics and there's suitability, and there's still a lot of rules that say you do what's in the best interest of your client, and that's regulated by the State Department of Insurance and the Code of Ethics and the rules. In some cases, it does meet the threshold for a fiduciary responsibility. In other cases, it doesn't. But it doesn't mean there's nothing there. It doesn't mean there isn't agency and goal alignment and all the professional things. And I would well, first of all, I would end on two things. One, Jacqueline, thank you for that great work. That was a lot of work in a short amount of time, and I think that'll be useful to our audience. And also, I would just say that the local community based broker is the professional who's charged with seeing to the client's needs, so seeing to the beneficiary's needs. That's whose job it is to do that, right? Helping you have the right yardstick to pick a health plan, helping a client to know what they might want to consider when picking a primary care doctor. We help them be informed as they're making these choices, and we have their best interests at heart. And that's, of course, in everybody's best interest because happy clients are more compliant because they trust and believe what they're told because they feel more comfortable. They also refer other people when they're satisfied, which means you don't waste a lot of money marketing on these big commercials. You've got a good referral base because you've earned it, and word of mouth travels fast, and everybody in that local community, they're caring about their constituents, they're caring about their congregation, whether it's a church or a food pantry or an office of the aging, the housing administration. All those administrators, they care about the people that they're charged with serving, and they will not let you in if you are not worth your salt, and they will definitely report you or kick you out. But if you are, then they can know that it's a good service to provide a professional who understands this, who has goal alignment with their clients. And so I see a lot of people in the government and the legislative and in the policy side, they only know about the bad story. I saw a congressperson who I won't name, and she was talking about stuff from Joe Namath commercials, right? That totally like solving yesterday's problems. And so, we have to solve today's problems, and we have to plan solutions for tomorrow's problems. And we don't want to throw the baby out with the bathwater. You've got these great brokers across the country, and you've got these great FMOs that enable and support them, and they work as a team in conjunction, and they keep the carriers, you know, um, where they belong in terms of the value that they add and the way that the carriers compete. We're the ones who help evaluate the needs of the client and do that needs analysis so that they can find the right goodness of fit. So different carriers might focus in different areas as they compete and innovate, which is great. And the system is working. And I just hope that anybody watching this remembers that there's 100 great stories out there that you don't hear for every bad one that you do. And if you have further questions, contact us at Advocate Health Advisors, and we'll be happy to help you. If you want to sit down as a government official and anonymously sit at an enrollment or at a needs analysis with the beneficiary, we would be happy to host you in a kind of an anonymous way. With that, thanks everybody. See you next week.
Thank you.
Thank you.
Thanks.
Thanks
Bye.
everybody.